I might use it, but
You can use a combination of things. I mean, if you just use the knee immobilizer and it's sort of like it kind of biomechanically making that side longer, so it's kind of wedged into the floor, that's when also you might have to lift the other side with a half inch or something, full shoe length lift, not just a heel wedge. And then that gives a little bit of more length that maybe they can get this side out in front. But still, I'm still dragging my toes. The knee immobilizer is not going to do anything about that. So you can do the ace wrap deal also for the dorsiflexion at the same time.
right. Oh yeah, I used to do that a lot. I used to wrap right on the knee immobilizer, and then maybe even put something soft. We used to use the crane wraps on the shoe to decrease friction, so their shoe doesn't get stuck and they can bring their
Like a
shoe
slider.
Yeah.
Kind of like they have these. I think they're made in Canada.
Yeah.
They have these fancy things called sliders, and you can put them on the front of the shoe that try to just help to make it so there's not that friction of the rubber sole or the sneaker or whatever dragging on the floor. It gives a little bit of slipperiness.
If he has a lot of flexor tone and he's kind of doing the flexor withdrawal, then again, I'm going to get down on this stool and see if you can simulate that a little bit. So let's say he's on the left, he's coming way up. I'm going to just try and pull him down a little bit. And I'm going to get down at this heel and try to help him get that knee extension and work the knee. So read your cases and then think about a little bit of manual facilitation. Again, try not to over-facilitate. If there's a little bit of movement, let the patient initiate, because if you just move everything for them, they're not going to get stronger. However, if there's very little movement and you're gait training someone super, super slow and waiting for them to move, you're not really getting them into the groove of a normal gait speed, and the normal motor plan that we all have stored is kind of walking at a certain speed. So that's why sometimes you brace, you get another person, and you just kind of get them going to see if any of those motions kick in automatically, and sometimes they will.
Not that it was necessarily part of this lab, but then, this is your therapy session for an hour or two a day, then how, are you going to position them in the wheelchair outside of therapy? Those people that have the extensor tone, those folks sliding out of their chair constantly onto the floor. So, how are you going to keep them safe back on the nursing unit, when they're not having therapy, stuff like that? How are you going to position that pusher in a wheelchair so that they're not really, misaligned in their chair down on the nursing unit?
Yeah, that's a good point, and that actually was on the lab too. So some key things you want to look at is the length of the leg rests. You want somebody's knees and hips to be about level. You don't want them up too high. You don't want them too low. You can adjust the foot plates. You can look at the back of the wheelchair. If somebody has really poor posture and they're in one of those sling backs, that's not doing anything. You might need to recommend a more solid back. And we'll go over wheelchair equipment more in the summer, but just to get you thinking about a little bit of positioning. Because you can work with a patient for an hour and get them in good postures and have a mirror, get them all aligned. And then if they sit in this lousy wheelchair with the legs all wonky and the sling rest, and they're in that for the rest of the day, you've just undone everything you did. And that's a reality, unfortunately, of a lot of clinics where they don't have great equipment or therapists that are specialized in the equipment and looking at what you do have and making modifications. We used to roll a towel roll up to get a lumbar support. Some of our wheelchairs, if the legs rest weren't working very well, we get the tools out, we try to adjust, we do the best that you can to make modifications for postural and seating. But think about feet flat, knees and hips aligned, good posture in the trunk. If they're in a sling back, you can recommend a solid back or raise the back up a little bit to have their posture better. If their posture's pretty good and they're high functioning, you don't want to overdo it and give them this fancy wheelchair with a J back and a fancy Roho cushion if they had their knee replaced and they're going to go home, because guess what? They're going to say, I want to take this wheelchair home. Can you order me this chair? And there's no way insurance is going to pay for that. So you want to think about that too. Don't give somebody a Cadillac if you know insurance isn't going to approve them to go home in it. You can overdo it sometimes too. So that's another consideration.
If we're transferring somebody bed to chair and they have a flaccid side, are we transferring
transferring him to a chair or to a wheelchair, what's going to be easiest? Towards his good side, unless he's a pusher. Then actually it's going to be harder, but don't worry about the pusher too much. Yeah, it's going to be easiest to go to his good side. So the first day I see somebody in acute care, I'm in there by myself, I don't really know the patient, I'm going to go the easiest route. As you get going with your therapies, you want to teach the patient to go both sides, because depending on how their bed's set up at home, or where they're going to, how they're going to transfer in and out of the car. But yeah, you would go towards the good side. Towards the good side. So I would want him to go this way. And that's because he can reach for the armrest if it's a wheelchair. He can push with this leg. He can probably do that without weight bearing through this leg at all. If he does do that, then where do you want to be? On the weak side, right? You want to come down. You might block the knee. You're going to get down low under his hips. You're not going to block this knee because it works. And a lot of therapists make that mistake. Don't overguard the good side. Let that side do its job. Come over here, block his knee, get down low, cue him to move, and then go. That would be like a sit, pivot, sit. Yeah, ultimately you should go both ways. Yeah, and practice that. You want to practice different heights too. Change the environment, make it easier, make it harder. Yes?
Now, like going to either side and it's a flaccid arm, you wouldn't really emphasize using that arm, correct?
No, because he's not really going to be able to use it. If there's a little bit of function, maybe just the hand is flaccid, but then I would try to get him to incorporate it, because the eventual goal is for him to use it. But if it's totally flaccid, I'm probably just going to get it out of the way so it's not dangling. Yeah. Any other questions?
Do you want me to show that side for you? Also?
Yeah.
You
Yeah.
want to do this way?
Sure.
So, I learned this from somebody I used to work with a long time ago. It's kind of like an MDT thing, sort of. But there's all different ways to position yourself with this initial sit to stand. If they need a lot of trunk help, then you have to be up here at their trunk. If they just need more leg support, you can be down here and kind of focus your attention down here on the heavy leg. But sometimes if they need both, it's kind of nice to try to be able to do both. And so if I kind of cross my, I'm going to sit right next to her and cross my leg over her leg. So now I'm going to use my leg to help control the knee, but then I can still use my hands with the trunk. And this would be my favorite bedside table. And we're going to put both hands on. And then, so we're going to, I don't want to lock up her knee so much to prevent her the forward translation over her foot. The tibia has to come forward to stand. So I'm going to kind of back off a little bit, but we're going to start to stand up, and then I can use my leg to kind of guard the knee. And, I can even use my hip to help her hip. So like I feel like I have her locked in here pretty good. If she started to buckle, I could put in more pressure. If she started to lose her hips back to the bed, I feel like I have a hold there, and then I can, whatever I need to do up here, on her low back or on her chest, on her upper chest there, to try to work the trunk. You can even work the weight shift this way, and then once I weight shift her onto this leg, I might start to back off and see if she can hold that. You can do the tapping to try to encourage the quads and weight bearing, and then if she starts to buckle a little bit, then I can kind of I can build in a little more pressure with my leg. And it's just another way to try to use your body. You have to use your body. Like sometimes it'd be nice to have like 4 more hands, but it's just a way to try to use your body to help yourself, because you feel like you want to be doing a bunch of things all at once.
Yeah, that's a great point. And different therapists prefer different ways. When I treat in the clinic all the time, I really like to be on the left side when I weight train somebody. I just felt stronger that way. I could handle somebody. I like to guard on that side. My colleague preferred the other side. So you'll feel that as you